Hello, my name is Usama Naga. I will discuss in this section lumbar puncture in pediatrics. My objectives in this presentation: how to increase your success with infants and children spinal tap or lumbar puncture, understanding CSF analysis, critical points we need to know about management of meningitis, pearls and pitfalls in cases of meningitis. You can follow with me the Pediatric Board Study Guide, Meningitis and Encephalitis in Infectious Diseases chapter, page 251 to page 255. Indications for lumbar puncture in general: suspected meningitis or encephalitis. This is the most common indication in pediatrics. Febrile seizure in infants less than 12 months. Strongly consider lumbar puncture in any infant less than 12 months presenting with febrile seizure. Inflammatory like Guillain-Barré syndrome, multiple sclerosis, metabolic diseases, for example non-ketotic hyperglycemia or glycine encephalopathy, leukemia. Lumbar puncture is used for diagnosis and intrathecal therapy like in cases of ELL or EML types of leukemia. Contraindications of lumbar puncture: if the patient is unstable, cardiorespiratory compromise, signs of cerebral herniation, signs of increased intracranial pressure, for example apnea, bradycardia, hypertension, dilated or sluggish pupil, papilledema, focal neurologic signs, previous lumbar surgery, skin infection over the LP site, coagulopathy, or receiving anticoagulants. Very important to know, antimicrobial therapy should not be delayed if lumbar puncture is contraindicated. Consult a neurosurgeon in cases of VP shunt. Consider consulting anesthesiologist or interventional radiologist in cases of scoliosis or congenital abnormalities of the spine, obese patients with difficult landmarks or other difficult cases. Preparation for lumbar puncture: sterile gloves, spinal needle with stylet, skin prep and sterile drapes, collection tubes 3 to 4 tubes, gauzes and bandage, manometer in some cases if you want to measure the opening pressure like in cases of idiopathic intracranial hypertension or pseudotumor cerebri. It is very important for us to understand the needle size before we perform a lumbar puncture. The most common size we use in pediatrics in infants and children less than 3 years of age is 22 gauge 1.5 inches. In older children more than 3 years of age, we use a longer needle with the same gauge 22, 2.5 inches. In adolescents and bigger size children, you will use a longer needle, 3.5 inches. The gauge either 20 or 22. 20 is wider than 22. Of course, we have the choice to use between narrower and wider. The narrower is better because this will decrease the chance or the risk of CSF leakage. There is a formula, suggested formula, to help us to understand how far we can go while we are performing a lumbar puncture. This will increase your success rate in obtaining CSF. This formula is 0.03 centimeter times the height in centimeter. So if you have a boy, 5 years old boy with height 110 centimeter, you can use this formula to understand which needle you will use and how far you can go. 0.03 centimeter times the height in centimeter 110, this will give you 3.3. So you can use this needle. This is the appropriate size for this child, and you can go while you are performing the lumbar puncture. This is how far you can go. This will increase your success if you are wondering if you are performing the procedure correctly or not. So this is just a suggested formula to help us to increase our success in obtaining CSF. Before we perform the procedure, we have to obtain a consent from parents or guardian in order to be able to perform a lumbar puncture on a child, explaining all risk and possible complications. Herniation is extremely rare, but we have to examine the child, complete neurological examination, examine the eye for any signs of increased intracranial pressure or focal neurological signs. Using analgesia is humane. It's very important to use it even for neonate. It's a painful procedure. You have to know that. Headache is a possible complication of lumbar puncture, so you can use analgesia afterward is appropriate. Taking a good history that the child is not taking anticoagulants or there is no history of coagulopathy. Infection can be avoided by using sterile equipment, sterile gloves, complete aseptic technique. Subarachnoid epidermal cyst, using needle with a stylet will decrease this risk. Using a narrower gauge will help to decrease the risk of CSF leakage. If the parents refuse the procedure, do not delay the antibiotic administration. Using EMLA cream before the procedure is very important. Even in neonates, this will decrease the pain while you are inserting the needle, even if you are going to use local lidocaine or local infiltration anesthesia. So EMLA is lidocaine and prelocaine, and you can use it 30 to 40 minutes before the procedure. Lateral decubitus position is easier and is the preferred position to obtain CSF. It's easier to align the back along the table to be parallel, so this will decrease the chance of unsuccessful procedure, and also less incidence of post-puncture headache, especially in older children. And this is the position you are able to measure the opening pressure. So palpate the iliac crest, the superior iliac crest, with your index finger at the same level you have your thumb, and this will be the space between L3 and L4. You can go down to obtain the CSF between L4 and L5. So you use your thumb as a guide to direct the needle, and when you insert the needle, it has to be with a stylet exactly in the midline, not above, not below. If it's above or below, there is very likely that you will not obtain a CSF, you'll obtain blood. So in the midline exactly, and direct the needle slightly about 15 degrees towards the umbilicus. Sitting position is another option. The back has to be arch and also perpendicular, not leaning to one side, in order to be able to obtain CSF successfully. Locate the site of needle insertion by palpating the superior iliac crest with index finger at the same time, at the same level you are palpating the spinal process. So you are able to use between L3 and L4, or you go down between L4 and L5. After identifying the site of needle insertion, wear sterile gloves, use antiseptic like betadine or chlorhexidine, and cleaning the skin in a circummotion manner from inside to outside 2 to 3 times. Apply drapes and arrange your tubes in order from 1 to 4. Knowing the anatomy of the spine will increase your success rate in obtaining CSF. When you insert the needle, you will penetrate the skin, then subcutaneous fat, then supraspinous ligament, then the thickest part is intraspinous ligament. As you see here, the fibers of intraspinous ligament along the axis of the spine. This will explain why the bevel has to be in certain position. Then you will hit the ligamentum flavum, after that the posterior epidural space, then dura, and finally arachnoid. After the arachnoid, you will be in the subarachnoid space. This is where the CSF will come from the subarachnoid space. So why is it important to know the anatomy? For example, if you are inserting the needle and your angle is very high, cephalic, you will hit the bone above, and this will give you resistance. So you need to back up a little bit without exiting the skin and direct your angle more or less 15 degrees towards the umbilicus. Or the opposite, if you insert the needle perpendicular, direct like that without angle, you may hit the bone below and you find a resistance. You need to back up slightly and direct your needle towards the umbilicus, and this will increase your success to obtain CSF. Now it's time to perform the procedure. Before doing that, confirm that the back is still parallel to the table. The infant or the child in a good arching position, arching like a cat, or in a fetal position. This will give you a good space between the spines and easier insertion of the needle. Palpate again the superior iliac crest with your index finger at the same level parallel to your index finger, using your thumb palpating the spinal process, and using your thumb as a guide to guide the needle 15 degrees towards the umbilicus, and insert the needle exactly in the midline. When you insert the needle, it has to be with a stylet in place, and once you pass the skin, you have an option to remove the stylet early and advance slowly until the CSF comes. And when you obtain the CSF, collect 1 ml in each tube. 3 to 4 ml are enough for CSF studies. After it's done, insert the stylet back and remove the needle and apply bandage. Very important to know how to direct the bevel while you are performing the procedure. In lateral recumbent position, bevel has to be up, so in this case you do not lacerate and you do not cut, you just separate. And if the child is sitting, you need to use the bevel to the side, to any side, right or left. In this case, you will separate and you do not lacerate. Unfortunately, sometimes you obtain just blood or no CSF, or nothing is coming at all. In sitting position, the possibilities are if the back is tilted to one side, as you see here, the needle will be out of the space, will be of the space of the subarachnoid space. You will see just the blood is coming or nothing is coming at all. Also, if the needle is too advanced further or offline, you may not obtain CSF, you may obtain just the blood, or it's too shallow. So also knowing the distance, how far you can go, this also is very helpful. So we need to make sure that the child back is straight and you are inserting the needle in the midline exactly, and also you need to know how far you can go approximately using the suggested formula we mentioned previously. This can happen with lateral recumbent position. If the back is curved downward or upward, the needle will be of the space of the subarachnoid space. So it's very important to align the back with the table to make sure it's parallel to the table, inserting the needle exactly in the midline. Also, too shallow or too deep can give you blood or no CSF at all. Knowing the approximate distance, how far you can go, is very important and will increase your success rate. Problems can happen while you are performing the procedure. So troubleshooting here, if you have a bony resistance, the needle is not going any further, do not insert anymore, just back up slightly, withdraw without exiting and redirect the needle to the correct angle. If you obtain CSF, then the flow stops. Do not remove the needle, just rotate the needle 90 degrees clockwise and it's very likely to have the CSF flow back. If the CSF is bloody and is not clearing, retry again after reviewing the angles and position. Use a different needle if the needle was removed completely. If the child is constantly moving, add another person to hold the infant or the child, or to be done under sedation or using of analgesia. Summary and tips. Identifying the correct site of needle insertion is the most important step in lumbar puncture. Using analgesia, it's a humane, it's a painful procedure. Apply EMLA cream 30 to 40 minutes before the procedure. Use oral water sucrose in neonates, local infiltration with lidocaine, or even sedation in some cases. Allow good arch without compromising the breathing of the child. This will give you a good space between the spines without having a high incidence of bony resistance. Long axis of the spine should be parallel to the table in lateral recumbent position. Insert the needle with bevel up in lateral recumbent position and style it in place. May remove the stylet early after passing the skin and advance slowly. This may increase your success rate in obtaining CSF. Know the angle. It will be toward the umbilicus, about 15 degrees. Patient must be stable for this procedure. If the patient unstable, you cannot perform lumbar puncture. You go ahead and start the antibiotics and provide appropriate resuscitation. Never aspirate to obtain CSF. Send tube 1 for culture and gram stain, tube 2 for glucose and protein, tube 3 for cell count and differential, tube 4 for additional studies, for example, viral culture, enterovirus PCR, herpes simplex virus PCR, CSF metabolic studies, or even cytology in cases of leukemia. Ordering latex agglutination test does not change the treatment plan and it has limited benefits, so no need to order these tests. After successful lumbar puncture, now it's time to know how to understand the CSF studies, how to differentiate between viral meningitis and bacterial meningitis. In cases of enteroviral meningitis, the white blood cells in the CSF will be less than 1,000, is more than 1,000 in most of the cases of bacterial meningitis. Neutrophils will be here low, will be 20 to 50%, here will be higher, 85 to 90%. CSF glucose here is more than half of the serum. For example, if you have serum glucose is 80 milligram per deciliter, here will be like 50 or 60, here is 30 or 20. Protein here is low, protein here is high, is more than 1 gram per liter. Negative gram stain here, positive gram stain in 60% of the cases. Negative CSF culture here, positive CSF culture, especially if no antibiotic was given before. If antibiotic was given before the lumbar puncture, this may make the diagnosis more challenging or difficult. In cases of enteroviral meningitis, as we mentioned, the CSF or white blood cells in the CSF will be less than 1,000. Here, it can be less than 1,000, between 500 to more than 1,000. So very important to know that sometime in rare cases of meningitis, you may have few white blood cells or no even white blood cells in early course of the disease. So absence of white blood cells in the CSF does not rule out bacterial meningitis. Neutrophil in cases of enteroviral meningitis between 20 to 50%. Here will be more than 60%. This is a differentiating point. The CSF glucose here is more than half of the serum. Here will be still less than half of the serum to normal. Here the protein is between 0.4 to less than 1 gram. Here between 0.7 and more than 1 gram. Here is negative gram stain. Here is positive gram stain in 60% of the cases. Negative CSF culture here, negative CSF culture between 29 to 44% of the cases. So this may make the diagnosis very challenging, but helpful points: if the CSF glucose is low and the CSF protein is elevated, positive gram stain is helpful, and positive CSF culture is helpful, but if it's negative, does not rule out bacterial meningitis. In this case, you will depend on the blood culture result. Very important to understand CSF studies in a special situation. For example, if you have a patient with suspected meningitis and you did a CSF studies and showing low glucose, high protein, and no or few white blood cells in CSF, in this case you have to continue empiric antibiotics until culture results are known. If you have a gram stain is positive for certain bacteria, for example E. coli, you have to continue empiric antibiotics until culture results are known. So do not narrow the spectrum depending on gram stain only. You have to wait for the culture. If you have a traumatic lumbar puncture, the way to differentiate between blood and blood mixed with CSF is to allow one drop or few drops to come in a dry gauze, and if you see a hollow around, this means the fluid containing CSF. In this case, you go ahead and send it, and there is a formula to be able to understand it. For each 1,000 red blood cells, you have normally 2 white blood cells in the CSF. This is approximate. So if you have, for example, 10,000 red blood cells, in this case, normally you will have 20 white blood cells in the CSF. This is approximate. So what to do in this situation? You have also to continue empiric antibiotics until cultures or until culture results are known. This is a very important question. Do we have to do a CT scan or neuroimaging studies before performing a lumbar puncture in pediatrics? The answer is no. Clinically stable children with suspected bacterial meningitis and no clinical signs of brain herniation, promptly you have to do LP without delay. Indications for neuroimaging or CT scan before lumbar puncture: focal neurologic deficit, papilledema, coma, apnea, bradycardia, hypertension, sluggish or dilated pupils, VP shunt, CNS trauma, or neurosurgery. Very important to know that normal CT scan does not mean it's safe to perform LP in children. So you have to go with clinical signs. If CT scan is indicated, you have to withdraw blood culture first. Then start the antibiotic immediately, then send the child for CT scan. Do not delay antibiotics to perform CT scan. All cases of meningitis, they have to receive empiric antimicrobial therapy until all cultures are negative. In neonates, give ampicillin and cefotaxime. Ampicillin to cover for group B strep listeria, and cefotaxime to cover for E. coli and gram-negative bacteria. Children 1 month and older, give vancomycin plus cefotaxime, either cefotaxime or ceftriaxone. If you suspect resistant Streptococcus pneumoniae, cephalosporin non-susceptible, penicillin non-susceptible, consider adding rifampin to vancomycin plus either cefotaxime or ceftriaxone. If the CSF profile is unremarkable and all cultures are negative, safely you can stop the antibiotics. If the CSF culture is positive, you have to continue the antibiotics for a certain time, and we'll know that in the next slide. Very important to decide about length of therapy. Uncomplicated meningitis, 10 to 14 days if Streptococcus pneumoniae, 7 to 10 days if Haemophilus influenza bacteria, 5 to 7 days if Neisseria meningitis, 14 to 21 days is longer in cases of Listeria monocytogenes, minimum of 3 weeks if it's gram-negative bacilli. What to do if culture negative CSF? If you have unremarkable CSF study or profile, negative blood and CSF cultures, discontinue antibiotics. If you have positive blood culture, CSF pleocytosis or increased white blood cell count in the CSF, negative CSF cultures, in this case you continue antibiotics because you have positive blood culture and the possibility of meningitis because of abnormal CSF profile, as if the CSF culture has been positive. Do we need to repeat LP after starting antimicrobial therapy? American Academy of Pediatrics Infectious Disease Committee recommended that all infants with gram-negative bacilli meningitis, they have to have another LP 24 to 48 hours of therapy to ensure sterility of the CSF. Some experts, they recommend repeating LP 24 to 48 hours of therapy in all neonates with meningitis to confirm CSF sterilization. I suggest here to follow the protocol in your NICU for cases of neonatal meningitis. If on repeat of LP the culture remains positive, you have to re-evaluate the antimicrobial regimen you are giving, and another LP should be performed. Do we need to give dexamethasone for cases of meningitis? American Academy of Pediatrics recommended for infants and children 6 weeks and older, if the CSF profile looking bacterial, to give dexamethasone before or at the same time of antibiotic therapy. There is no benefit to give dexamethasone if the antibiotic already given 1 hour or more. So less than 1 hour it's okay, but after 1 hour there is no benefit. Why we give dexamethasone? Because cases of Haemophilus influenza meningitis, if you give dexamethasone, this may decrease the rate of hearing loss and neurological complications. Clinical case scenarios: we have to perform lumbar puncture. Fever in less than 30 days old, we have to do lumbar puncture. Is a part of the septic workup, included with urine culture, blood culture, chest x-ray. Infants presenting with fever, fussiness, inconsolable cry, and there is no explanation, sleepy, jitterness, seizures. 20 to 50% of the cases of meningitis, they may present with seizures. Infants presenting with febrile seizure less than 12 months, strongly consider LP. Older children, they may present with fever, headache, lethargy, irritability, confusion, photophobia, nausea, vomiting, back pain, stiffness. Very important to know, at any age, negative meningeal signs does not rule out meningitis. If you suspect meningitis, you have to perform lumbar puncture regardless. Finally, perform LP in any child with suspected meningitis. Know that CSF culture is the most important point in making the final diagnosis of meningitis. Positive blood culture is very helpful if the CSF culture is negative. Never delay antibiotics for imaging studies or for LP if the patient is not stable. So go ahead and start the antibiotics while stabilizing the patient, and do not delay for LP. Consult the experts in infectious diseases. If you have cases of recurrent meningitis, especially recurrent same organism like a recurrent staph or recurrent E. coli, immune deficiency, recurrent Neisseria meningitis, for example, like in complement deficiency, drug resistant, persistent infection, CSF leakage, penetrating head trauma, recent neurosurgery. Normal CBC, normal CRP, negative blood culture, negative meningeal signs, none of these will rule out meningitis, only LP or CSF studies. Learning how to perform lumbar puncture is a must in pediatrics. Please share with us your experience with lumbar punctures and your suggestion in the comments below. This is the end of this presentation. Thank you for listening. This lecture is only for educational purpose and not intended to direct care of any specific patient. Please consult your physician and the physician of your child for the correct diagnosis and the proper treatment. None of my videos can be superior or an alternative for the opinion of an experienced and licensed healthcare professional. Thank you again.